Okay, we have a case sent to us. Looks like it's for an immediate placement and tooth number 9. And we can take a quick peek here at the area. And we have a good scan. We have good CEREC data here. We have a virtual tooth design. One of the things I do want to point out very nicely done on this one um, is that our original tooth is actually rotated. And what was done here was the final tooth or the proposed or virtual tooth was designed based on ideal restorative outcome. So we're not going to actually make a crown that's rotated. The plan is to make a crown that is ideal here. So this case was sent to me, and here was the note sent is 47-year-old male with a chief complaint of loose crown, has noted that number 9 has been mobile for 15 years. It's interesting that it looks like the bone grew over the root in the scan. Would you use the osteotomy to help section the root? So we're going to use these notes to determine kind of what we are evaluating here. So let's go ahead and go here to the implant align view. There is a plan here in place. So what I would like to do is duplicate the plan. That way we can compare my plan versus the plan given. And the first thing I'm going to say is let's forget about the implant placement, location, and all of that. Let's focus on the bigger question here, and that is this an appropriate case to do immediate placement? So how do we determine that? So what I would like to do is leave this plan here and let's just assume the implant is a good implant, it's the ideal placement, everything's perfect, but this is our plan. So let's take a peek here and we'll do a magenta line just like so around the existing root. And there's the crown, just like so. So my first comment on this will be that really the only area that we have making stability for us is that part of the implant. So we have to question whether or not there will be enough stability with this implant plan as it is. And we're already using a 3.7 by 16 millimeter implant here. So the next question is buccolingually, are we engaging bone maybe a little bit sooner? So let's take a peek here. And this time in yellow, I will draw the root of this tooth. So kind of like so is the root, and there is the crown. So here we can see, and I'll do this one in, let's say, green. Here we can see that maybe we have just this area right here that's engaging bone. Now what we do have to know is when we take the tooth out, we are going to be expanding the socket. So we may not even have this part of the root right here engaging into the bone. So the bigger question, again, the most important question in this case is this a good case for immediate placement? Then the next thing we have to look at is, can we go longer? I mean, and I don't know how much longer than 16 millimeters we can go, but we technically could go longer here, but we don't have a longer option to go with. So these things may lead me to believe that this may be a case that would be better suited for grafting followed by implant placement. Now, me personally, I'm always a big believer in giving it a chance. So I may make a plan to do the implant and then have to make a game time decision, maybe have to punt and determine that this isn't the better situation. Another option is, could we go to a wider implant? Now when we get into a wider implant here, we can see that we're going to start engaging bone a little bit sooner, but we also have to realize how thin we're making it on the buccal plate here. So my first step is primary stability. Now, to me, the next most important thing, and that we have to deal with immediate placements, especially in the anterior, is the buckle plate. So here we can see that we have a nice cortical plate here, but let's go back to the original size here. Is that too close? Are we going to have this cortical plate here after we take the tooth out? Are we going to have to expand and rotate and kind of shimmy this tooth out, this root out, and then not have a buccal plate left, or maybe have a dehiscence in the buccal plate? Or maybe there's a dehiscence somewhere that we're not seeing here as we rotate through. And as we rotate through, it actually looks like our cortical plate is well intact here. But these are some of the things that I'm taking a look at in this particular case. So with that in mind, what I may consider doing on this case is simply tilting this back like so. Now what this does is gives me more space up here, and by tilting it, I'm starting to engage the bone a little bit sooner and more in this particular case. So now stability may not become as big of an issue. The next thing I would consider is, how would this affect my osteotomy sequence? In other words, would I follow manufacturer protocol for ideal osteotomy? Or would I simply do a 2mm pilot drill and try to engage and expand the socket, assuming that this is an end cutting implant, but which is not? How would that work? So in this particular case, one of the things I may want to consider is going to a slightly different implant. So I would consider going to an active 3.5 by 15mm implant. It's an end cutting implant. I could likely do a 2mm osteotomy only and then be able to extend this implant into place. The other thing I could do is it offers me a longer implant. So now I can go 18mm, and suddenly stability is not that big of an issue. Technically, I could probably even consider doing something like this. This is a bit more risky, maybe not for the faint of heart, but certainly now suddenly I'm a little more comfortable going into immediate placement with this particular implant now. So these are the issues that we're looking at. Quite frankly, the plan that was presented was well planned, well done. If we look at anything, we're slightly off to the distal right here. So maybe what we need to do is just tilt the tooth a little bit that way. And, in an ideal world, I would want this to come out the incisal edge and or to the palate. But in this particular case, I am not going to mess with it too much, simply because I do not want to disturb the buccal plate or lose even the palatal plate here. So this is definitely a tougher case. This would be a case that I would be prepared to flap if necessary and graft on the buccal in case there were a dehiscence in any of these areas right here. I would be prepared to do a single osteotomy, a 2mm pilot, and try to expand and condense and place my implant using an end cutting implant with aggressive threads. The legacy 3 threads, as they were planned here, are relatively aggressive. But my concern is they don't make an 18mm length implant, so we're limited in how much engagement we can get. And it's not an end cutting implant, so I'm not certain that it would be able to start engaging in the 2mm osteotomy and allow us to achieve depth. If I wasn't able to achieve depth with the 2mm, then I would back out the implant, go to the next size, and try to place the implant again. I would consider some maybe osteotome bone expanders in this particular case. So there are, again, quite a few things that we have to take a look at, but the implant plan as presented was pretty well done. Again, the only thing that I changed was we can take a comparison is here. This plan has more room to the palate right here. Very thin buccal plate here. I would be very uncomfortable with this. So what I did in my particular plan is just centered this slightly better, cheated off towards the palate, created more room in here, allowed me to get a little more engagement and extension here, and so forth. The only other thing now we need to consider is how we're going to get the tooth out. The tooth will come out. Is that bone there? We may have to do a little bit of bone drilling right here. How is that going to affect our placement? Maybe we need to plan for a deeper placement and then back the implant down once we place it based on how the bone level comes out from the extraction. But these are some of the things that we have to be prepared for. So a very good case, and thank you very much.